Oh, sorry about that. I had somebody at the door, had to answer it. But anyway, finally, we're at my class of drugs that I appreciate the most, and that is the SSRIs. They really are your first line, and I love them because oftentimes you'll see improved mood more quickly than that 12-week window. Even up to 3 to 4 weeks, you'll start seeing some successes. If it's a gentleman, my preference is Zoloft. If it's a lady, my preference is Prozac. Everybody has their own issue of what they like. There's also Paxil, which is very good for social anxiety. Celexa, Lexapro, to me, those really, I haven't seen a lot of really strong success with those. So I would use them more in the elderly, because you need lower doses usually for the elderly anyway. And then Luvox, which is, it's okay. It's probably the newest one out of all of them. Basically what they do is they block the reuptake of serotonin in the synapse, so we have more of it hanging around, which is what we want. Makes you smile. So some of the other ones, the new atypicals I told you before, is the serotonin norepinephrine. The bad thing about those is if you're blocking the reuptake of norepinephrine, it's going to cause, it can cause insomnia, it can cause some jitters, so you don't want to use those at bedtime. If you're going to give those, you're going to give them during the day when they're going to be more awake. Atypicals, Zyban, bupropion, Wellbutrin, I give that to depressed patients that want to quit smoking, so it does work wonders. Remeron is more of a sleeper. Effexor and Cymbalta, those are your SNRIs that we use in diabetes, SNRIs. They have that extra effect for neuropathies and pain control in general. Prestique, it's real expensive, it sounds pretty. It does the same thing as everything else. And then Trazodone, which is a sleeper, and you'll see that in nursing homes too. There's a lot of Trazodone. Side effects of the antidepressants. Anticholinergic. If you remember anything about anticholinergics, remember that they dry you up. Okay, so anticholinergic side effects are going to be dry mouth, blurry vision because always humor's getting dried up, urinary retention, constipation, anything dry mouth. Anything with an anticholinergic nature is going to do that to you. It's also alpha-adrenergic, and that could be the heart racing, the norepinephrine, fight or flight simulation, histamine blocking, which actually can potentiate itching and things like that, decreased libido and weight gain. And I don't want to say it's excluding the SSRIs anymore, because some of the newer SSRIs, it gives a new meaning to the term fat and happy. So some of them are weight neutral, some of them cause you to gain weight. So that excluding the SSRIs, that needs to come off, so just scratch it out. Okay. Side effects of the SSRIs: headache, insomnia, agitation, GI upset, sexual problems, meaning that they have no sexual desires, weight changes, I mentioned the increasing sometimes, frequent stools or no stools, constipation, anxiety, and akathisia. Sometimes you can see akathisias with the SSRIs. Most of the time, the akathisia or the need to move all the time, restless legs, you're going to see that more with your antipsychotics. So let's see, serotonin discontinuation syndrome. Serotonin reuptake inhibitors you have to consider almost like your benzodiazepines. You introduce it slowly, you wean them off of it. Now, there's nothing in the literature that's going to tell you have to do that. Okay, you can have somebody who's on 80 of Prozac, PRN, 40 daily, 80 PRN, and they take their 40 every day religiously, and then they go away for the weekend and they forget to take their pills with them. Saturday starts with the headache, Sunday with the irritability, feeling sick to their stomach, being very anxious. That's serotonin discontinue syndrome, and it can happen within 48 hours of missing your dose. So It's almost like a withdrawal from the serotonin. Now, that being said, serotonin is not addicting, okay? People say, oh, your antidepressants are addicting. No, they're not. People are addicted to feeling good. They're not addicted to the pill, okay? They want to feel better, and I know everybody's going, oh my God, well, that's why people take heroin. They feel good. It's a different kind of good. It's a normal. They feel normal, okay? They don't feel drugged up or falsely elevated or depressed. It's normal. So it's not addicting, but you can have a almost withdrawal-like physiological response to going without, and that's called serotonin discontinuation syndrome, just so you know. Some of the toxicities, they can stop your heart. Overdoses can cause seizures, mania, the discontinuation syndrome. If you're taking the MAOs and you decide to go eat a whole block of summer sausage, you're going to have malignant hypertension, probably die. And then serotonin syndrome. And serotonin syndrome, and it's different than discontinuation syndrome. Serotonin syndrome happens a lot in women with PMDD, postmenstrual dysphoric disorder, or really extreme distress. And what it is you have too much serotonin on board for your progesterone levels. Your hormone levels have fluctuated, and usually the serotonin assists when you are really low in your female hormones with mood, and that's generally what keeps women who have PMDD straight in their mood and their attitudes. And then they wean it off as their menstrual cycle starts, and their hormones re-regulate. So usually with PMDD, those ladies know how to go up and down on their medication, and they may go from 20 to 40 to 20, within a week, and it's not going to cause a lot of issues. But if they stay on a standard 40 or a standard 60 or a standard 80, I'm talking about Prozac, most of the time it's fluoxetine is what's used for PMDD. If they're on a standard dose of that and their female hormones are waxing and waning, they can actually be at a point where they don't need any serotonin, and then they're giving themselves serotonin. So their levels are way up here. They have too much, and when they have too much, they have serotonin syndrome, which can be a hot mess too. Irritability, abdominal pain, diarrhea, tachycardia, seizures, shock. So usually what you have to do when they have serotonin syndrome, if they've come in and they're really extreme like this, we take them off the drug. Give it a little honeymoon time to do without, and then restart it at a different level, and begin the retitration again. Some ladies would not make it through life without their PMDD assistance. So, hypertensive crisis happens with the MAOs if they eat tyramine foods. Tyramine causes norepinephrine, which is a vasoconstrictor, which causes the crisis. Usually you see headache, stiff neck, tachycardia, high blood pressure, of course, hypertensive crisis, chest pain, and so we're going to give them rigidity to help offset, cause vasodilation. Now, if they avoid the foods, if they are good on their diet, we really don't have to worry about packing rigidity with us wherever we go. But it's mainly because of this dietary restriction that they don't prescribe these as much as they used to. If you see them, it may be 20 years down the road, but if you see them, stop, do a little review of the diet before you go ahead and do any kind of medicating. They have to watch out for aged cheese, avocados, figs, anchovies, bean curd, broad beans, brewer's yeast, liver, any kind of deli meats, salami, pickled herring, meat extracts, fermented foods like Chianti and kind of wine, Chinese food, all that stuff is going to potentiate tyramine. Can't use a whole lot of medications with the MAOs. You can't use antiasthmatics, antihypertensives, epinephrine, hay fever decongestants, cough and cold products that have the pseudoephedrine in them, can't do it. Buspar, meperidine, and you can't use SSRIs while you're using the MAOs. You're really not recommended to do that. Some doctors do. Just remember that. Okay. Patient education, obviously on the diet. Avoid St. John's wort. Teach them to avoid all that laundry list of things that I just told you about. And call the doctor if they start to experience problems with their blood pressure. Generally, overall on antidepressants, we're going to educate people. We're going to let them know that it's not addictive. Try not to drink when you're on it. It tends to exacerbate the lability of the mood when they partake in alcohol while they're on an SSRI. Educate them on the lag time. Tell them it could take up, and just go ahead and say 3 months before they begin to feel better. Okay, that way you're not instilling false hope, but you're giving them something to look forward to. And if it starts working in 3 weeks, beautiful. If it doesn't start working for 3 months, then maybe you've offset a suicide. Okay. This is kind of the timeline. It varies depending on the antidepressants. I know I've kind of belabored this a little bit. Week 1, lower anxiety, improved sleep, increased sex drive, self-care activities, concentration, memory. In the 1 to 3 weeks, 2 to 4 weeks, relief, depressed mood, decreased hopelessness, and suicidal ideation subsides at 4 weeks. But like I said, between that 2 weeks and 4 weeks, they're getting the energy back. And once they have the energy, if they still have the depressed mood, then we're at risk for suicide. It's the highest risk, actually. There's some pictures showing you a depressed brain and a brain lit up with serotonin because it's happy. So it shows you the response that we do have. Adjustment disorders. These can manifest in children, which is kind of a nice segue into our childhood psych.